Good morning, everyone. I see people still logging in, but I think it's time to start so we can finish on time. I would like to thank you for joining the 10th annual Kushner webinar. My name is Hilda Capó, and I have the pleasure of being your moderator today. This webinar is a collaboration between AAPOS and the University of Wisconsin. So before we begin the presentations, I would like to tell you a little bit how the whole event started. In 2015, when Dr. Burt Kushner retired from the University of Wisconsin, the university established an endowment to create a named lecture in his honor. This lecture usually will focus on strabismus and pediatric ophthalmology. We have a committee that selects the speaker of the year. AAPOS provides a platform for the webinar, and the University of Wisconsin offers an honorarium and a bronze medal to the keynote speaker for their contributions to the meeting. The title of today's webinar is Strabismus and Advances in Research. And as you will see, it has a strong emphasis on congenital cranial dysnervation disorders. We are proud to announce that the distinguished 2025 Kushner Medal recipient is Dr. Federico Velez. In addition, we have 4 other outstanding speakers, Dr. Mary Whitman, Joseph Demer, Stacy Pineles, and David Hunter. Each of them will deliver a 15-minute presentation leading up to Dr. Velez's keynote lecture. Dr. Burt Kushner will then join us for a few closing remarks, and then we will conclude the event with a Q&A session. So please send questions and comments using the Q&A feature, and I will relay them to the speakers. So we're going to go ahead and start with our first speaker. This is Mary Whitman. She's an assistant professor of ophthalmology at the Boston Children's Hospital and Harvard Medical School, and she has particular interest on strabismus and genetic disorders. She will speak on genetic contributions to strabismus. Welcome, Mary.
You have to unmute. Mary, you're muted. Mary.
Sorry about that.
That's better.
I would like to thank the organizers for inviting me today and all of you for being here. When we talk about the genetic contributions to strabismus, the most important distinction is between paralytic and non-paralytic strabismus. The non-paralytic forms of strabismus are the common forms we see every day, where the eyes are misaligned, but both eyes can move fully. And these are, the ones that are about 3% of the population. When we talk about paralytic strabismus, we're talking about the congenital cranial dysnervation disorders, where the eyes are misaligned because patients are unable to move one or both of their eyes fully. These are much more rare, occurring in about 1 in 1,000 people. And in these disorders, we've identified many of the genes. So this morning, I'm going to briefly go over genes involved in congenital cranial dysnervation disorders, and then talk about some of our recent work looking at the genetics of the more common forms of strabismus. There are 2 mechanisms for the genetic causes of CCDDs. There are ones where they mostly transcription factors that are involved in the differentiation of neural progenitors into neurons, specifically of the motor neurons that control the eyes. And then there's a group of molecules that are involved in axon guidance, where the axons growing from the brainstem to the extraocular muscles get misrouted. We classify CCDs based on which cranial nerve is involved. If the abducens is involved, you can have either Duane retraction syndrome, horizontal gaze palsy, or Mobius syndrome. And if the ocular motor is involved, it causes congenital fibrosis of the extraocular muscles, of which there are 3 types: congenital ptosis or oculomotor synkinesis. Duane syndrome is an inability to abduct one or both eyes, and then with globe retraction on adduction. This is by far the most common CCD, and it can be isolated or syndromic. It can be autosomal dominant, but only 2 to 8% of individuals with an isolated Duane syndrome have an affected relative. We have found that bilateral cases are more likely to be genetic. We find that CN6 is thin or absent in patients with Duane syndrome. CN3 can be thin or can be normal. And we find branches of CN3 that innervate the lateral rectus, leading to the retraction. There have been 2 genes identified that cause an isolated autosomal dominant Duane syndrome. One is CHN1, which is a RAC-GAP protein that's downstream of many signaling molecules. The other is MAFB, which is a transcription factor that is expressed in the hindbrain. Depending on the specific variant of MAFB, it causes Duane syndrome with or without hearing loss. There are also multiple structural DNA variants that have been associated with syndromic Duane syndrome. When we look at CHN1, it encodes alpha-2 chimerin, which is a downstream signaling molecule. The specific mutations are specific missense mutations that hyperactivate the protein. When we look at mouse models of CHN1 mutations, this is normal CN6 growing from the brainstem to the orbit. In a CHN1 mouse model, the CN6 stalls and it never gets to the orbit. In contrast, MAFB is involved in the differentiation of the CN6 motor neurons. And haploinsufficiency, meaning loss of one copy of MAFB, is enough to prevent the motor neurons from forming. And you get complete absence of CN6. And then you can see branches of CN3 come and innervate the lateral rectus in the mouse model. There are also 2 genes that cause syndromes that include Duane syndrome. There's Duane radial ray syndrome caused by SAL4 transcription factor, which is autosomal dominant. And there are 2 similar syndromes that we found have the same genetic cause that are loss of HOXA1 transcription factors. These are autosomal recessive and they cause a very complex syndrome of Duane syndrome, inner ear abnormalities, intellectual disabilities, as well as cardiac and facial weakness. And for CFUOM, there are 2 autosomal dominant forms and 1 autosomal recessive form. Patients are unable to elevate their eyes, and they're often stuck in introduction and have a resulting chin-up position. The horizontal eye movements are very variable, and patients usually have ptosis. It can be either an isolated eye movement disorder or part of a complex neurological syndrome. CFUM1, the disease gene is KIF21A, which is a kinesin, which is one of these motor proteins that carries cargo along the microtubules in the cell. Different kinesins carry different cargos. And the specific mutations that cause CFUM1, again, hyperactivate the protein. They prevent its autoinhibition. When we model KIF21A in a mouse, we see absence of the superior division of CN3. And you see this bulge here, which contains the axons that should have come down and formed the superior division. CFM3 is the most variable phenotype. It can be unilateral or bilateral. It sometimes does not include ptosis. Patients always have restricted vertical movements, but the horizontal movements are variable. They're usually exotropic, but there are some who are esotropic. And certain variants are associated with other neurological findings. The gene for CFM3 is TUB3, which is a tubulin, which forms one of those microtubules that the kinesins walk along. The microtubules are constantly forming and catastrophizing throughout the cell. When we model TUB3 in mice, we see specific axon guidance defects. So up here is a wild type. You can see the trochlear nerve here and the oculomotor nerve coming in here and branching. In the TUB3 mouse model, we see the trochlear stalls, and you get all of these abnormal branches of the ocular motor nerve. Specific mutations cause either isolated CFUM, where it's an eye movement disorder and patients are otherwise healthy, or complex neurological syndromes that include CFAOM and brain malformations. We've identified 2 specific syndromes associated with specific variants in TUB3. One is the E410K syndrome, and one is the R262H syndrome. These patients have very severe CFM3 with a large exotropia. Their eyes basically don't move. They also have facial weakness, intellectual disabilities, Kallmann syndrome, which is anosmia with hypogonadotropic hypogonadism, and various brain malformations. The RC62H kids also have severe joint contractures and peripheral neuropathy. So while most of them do learn to walk, they then lose this ability over time. This group of kids are the ones who are often misdiagnosed with Mobius syndrome because they have facial weakness, but they actually, cranial nerve 6 is the only, their only eye movement that works. CFUM2 is much more rare. It's the autosomal recessive form, and the eyes are sort of fixed in an exotropic position. To date, we've only identified it in families from the Middle East, and it's caused by loss of the transcription factor FOX2A, which is expressed at the midbrain hindbrain junction and required for differentiation of cranial nerves 3 and 4. So these patients just lack cranial nerves 3 and 4. All right. So to sum up on the CCDDs, there are two mechanisms. There are variants that disrupt differentiation of the neural precursors into the motor neurons, and there are variants that affect axon guidance. And identifying these genes has given us a lot of insight into normal development. I'm going to talk now about the common forms of strabismus and what we've learned about the genetics of those. We know there's a genetic contribution from family, twin, and population studies. About 30% of affected individuals have a close relative with strabismus. We see many families like this where multiple family members are affected. The concordance in monozygotic twins is much higher than in dizygotic twins, but it's not 100%. Esotropia is more common in Caucasians, while exotropia is more common in Asians and Africans. So we know there is not one single gene that accounts for all of strabismus, but it's not really known if different forms of strabismus have the same or different genetic risk factors, whether we should be studying esotropia and exotropia as separate diseases or all of strabismus together. We know there are non-genetic factors, including the known environmental risk factors of low birth weight, maternal smoking, prematurity, advanced maternal age. So people have looked at common strabismus as a Mendelian trait and identified a few potential loci, but no specific genes. There was a report in one family, this large family, they found a locus on chromosome 14, and the leading candidate is a non-coding variant near FOXG1. There have been a couple of genome-wide association studies looking for common variants associated with strabismus. These have both been in Caucasians, and each identified one single hit, one in an intron of the GET1 gene on chromosome 1, and one in the T-span 10 locus. Interesting, this particular locus has been found in GWAS for many other ocular conditions as well. But both of these did replicate in the FinGen dataset. There are other types of genetic variation besides single nucleotide variation. You can have copy number variants, which are large sections of the DNA that are deleted or duplicated, and then structural variants, which are rearrangements of the DNA. And these kind of variants can disrupt the genome. They can rearrange exons and alter regulatory regions and the 3D arrangement of the DNA. So we looked for copy number variants in strabismus because copy number variants have been implicated in many other neurodevelopmental disorders. And there are many syndromes that are caused by CNVs that include strabismus. So we examined our cohort of esotropia patients for CNVs, and we identified 3 recurrent rare duplications. We did not identify any specific deletions that were more common in strabismus patients. So these 3 duplications, one is on chromosome 4. It's a 23 kb duplication. It includes 1 exon of a long non-coding RNA, and it's in an area of the genome conserved only with primates and not with other mammals. One of them is on chromosome 2. This is a large 450 kb duplication. It includes a long non-coding RNA and a microRNA. And this is in a complex region of the genome with multiple repeats. And then the chromosome 10 duplication, also a large duplication, also in a complex region of the genome with multiple repeats. We looked, and these same duplications are also present in patients with exotropia in approximately the same proportions. And in patients with exotropia, presence of one of these duplications is associated with a worse phenotype, a higher magnitude of deviation, and a higher chance of having strabismus surgery. So in our lab, we have modeled the chromosome 4 duplication in induced pluripotent stem cells. We have to use a human cell because this area of the genome is not conserved with other mammals, so we can't model it in mice. So we introduced this duplication using CRISPR and managed to generate a line that includes the duplication. We did whole genome sequencing of that line to confirm that the duplication is there and there's no other mutations added. When we look at a mutation, the possible mechanisms are that it can disrupt a gene, it can disrupt the regulatory regions and change gene expression, or disrupt the 3D conformation of the DNA. So we differentiated these iPSCs into neurons using a 63-day protocol. And we look at them at day 14 when they're at the neuroprogenitor stage and day 63 when they're mature cortical neurons. They differentiate into neurons properly and they have normal neurite outgrowth in both lines. We then did RNA sequencing to examine gene expression of these cells and 4 separate differentiations. And we identified in the neuroprogenitors 23 upregulated genes and 32 downregulated genes. In the differentiated neurons, 12 upregulated genes and 25 downregulated genes. 18 of those were differentially expressed at both time points. And a number of these genes are associated with brain function. There's a number of protocadherins that are involved in cell-cell interactions. A potassium channel, CSMD1 is involved in synaptic pruning. And SLIT-RKT2 is involved in synaptogenesis. So we're currently working on the role of these genes in strabismus. And I just want to put one little plug in. If you're interested in the genetics of amblyopia, we have a paper in Press in Ophthalmology of a rare variant association study in amblyopia, and we identified 15 genes. And the identified genes are associated with neurodevelopment, not ocular structures. So we think that there is an underlying brain development issue that may explain why some people with the same ocular risk factors develop amblyopia and others don't. I would like to acknowledge all the people in my lab and all of our collaborators and funders, and I'll be happy to take any questions.
Well, thank you, Dr. Whitman, for such a beautiful talk and beautiful slides. I think we're really impressed with all those images of the nerves. So we're going to be taking questions at the end. Please send your questions to the QA app, and we can read them to the speakers at the conclusion of the session. So we're going to move on to our second speaker. That will be Dr. Joseph Demer. He's the Chief of Pediatric Ophthalmology and Strabismus Division and the Director of the Ophthalmology Lab at the Jules Stein Eye Institute. He holds the Arthur Rosenbaum Chair in Pediatric Ophthalmology at UCLA. As we all know, he's a world expert on orbital imaging of extraocular muscles. So he will speak on clinical anatomy of the orbit and cranial nerves in strabismus caused by the congenital cranial denervation disorders. Welcome, Dr. Demer.
Thank you very much. I am honored to be asked to speak in this session in which we recognize the enormous contributions of Burt and Kushner over the many years, and also in honor of Federico Velez. I give him my congratulations. I am very pleased to follow Mary Whitman and to greatly express my admiration for all the basic science work that she and her previous collaborator, Elizabeth Engel, have done to help us understand the development of motor neurons and extraocular muscles in the congenital cranial disinnervation disorders. And I'm going to be talking about perhaps a more practical kind of application of some of this knowledge to the clinical anatomy. Now, I'm going to be talking about only Duane's retraction syndrome, including the chromosome 2-related form, Duane's radial ray syndrome, and then congenital fibrosis of the extraocular muscles type 1. These are particularly common, as you know, although we have studied, and I will not talk about congenital oculomotor palsy, which resembles congenital fibrosis in many respects. I will not talk about Mebius syndrome, congenital ptosis, or congenital trochlear palsy, although these could also be imaged and qualify. Now, this is an example of a patient with dominant Duane syndrome associated with a chimerin 1 mutation on chromosome 2. Notice the phenotype here. He has a type 1 Duane syndrome in the left eye with limited abduction. The right eye type 3 Duane syndrome, limitation of both AB and adduction, and he exhibits an exotropia. So here are the 9-gaze photographs of this individual. He has centered horizontal gaze, a kind of lambda pattern with an exotropia in infraduction. He's also exhibiting limitation of abduction of the left eye and both horizontal directions in the right eye. So although we know the genetic, the genotype in this case, the phenotype for the same genotype can be quite variable. And I know this in this case because I've studied multiple members of this individual's family that all carry the same gene. So here we have a high-quality T2 weighted image of the region of the pons, where we will see the basilar artery and rather small vestigial abducens nerves, a small one on the right side and practically none on the left side. So one aspect of the endophenotype of this case is bilateral hypoplasia of the abducens or 6 cranial nerves. But something you might not have expected to find is that while the left oculomotor nerve, seen here at the level of the midbrain, is of normal size, the oculomotor nerve on the other side, the side where we have type 3 Duane syndrome, is markedly hypoplastic. Here we have the aqueduct and the 2 peduncles in the midbrain. So this aspect of the endophenotype might not have been anticipated if you were thinking of the classic manifestations of Duane syndrome as involving only the abducens nerve. Another finding in this case is hypoplasia of the optic nerve, not a motor nerve, but obviously a sensory nerve. So high-quality T1 imaging allows us to distinguish the sheath of the optic nerve from the nerve itself. We can measure the cross-sectional area of the nerve. The cross-sectional area of the nerve in the retrobulbar space runs about 4 millimeters in diameter, and it is significantly smaller at 3.6 in DOVS 2. This optic nerve hypoplasia, however, is typically not clinically significant. There's enough redundancy of axons in the nerve that visual acuity is typically normal, despite the fact that the optic nerve is small. So this is the endophenotype of optic nerve hypoplasia. Now, sometimes you will see some abnormalities of the extraocular muscles, and they can be quite variable in this condition. So I have colorized these images to keep you awake on this Saturday morning, but these are T1 weighted MRI images obtained in very thin sections in quasi-coronal planes using a technique of allowing us to control fixation. So we can image here in the center in primary gaze, attempted abduction, attempted adduction, and here we see in the opposite side central gaze. So what do we note? Well, there is hypoplasia of the superior rectus muscle. It is smaller than normal. We see an attempted abduction, little contraction of the right lateral rectus muscle in this individual with the type 3, but we also see some fissuring or abnormality of the cross-section. The right lateral rectus muscle is small and doesn't contract much, and that is reflective of the limited abduction. We do see some contraction of the medial rectus muscle. In the opposite side, the left orbit, which exhibits only the type 1 Duane syndrome, there is more profound hypoplasia of the lateral rectus muscle. And I would point out this little fissure demarcating the superior versus the inferior compartments of the lateral rectus muscle, as well as some dysplasia of the superior rectus and levator. They are chopped up into little broken segments there. So, we can also see multiple abnormalities in other members of this family. Note here in this quasi-coronal view of the left orbit, a small hypoplastic and oddly shaped superior oblique cross-section, a small superior rectus muscle with a little branch that's over to the superior oblique region, a longitudinal split in the lateral rectus muscle demarcating the border between the superior and inferior compartments quite specifically here. That is not seen as you come more anteriorly below, although you do see more clearly the dysplasia of the superior rectus and levator muscles. Most anteriorly, in the lower right, you would see an image that starts to be in the region that might be accessed by a strabismus surgeon. And of course, you would not have recognized any of these deep abnormalities if you only did a surgical exploration. So multiple abnormalities are disclosed in the endophenotype when good imaging is done. In that case also, we did a quasi-sagittal imaging parallel to the lateral rectus muscle. So this is in the very lateral part of the orbit. And we can see here that the lateral rectus is divided into a superior and inferior compartment with a nice fissure filled with bright fat in between the two of them. This longitudinal fissure would not be evident on clinical or surgical inspection. Now, Mary mentioned the Duane radial ray syndrome, called in the older literature the Okihiro syndrome. This is the phenotype. There's limited AB and or adduction of one or both eyes with globe retraction on adduction, lid fissure narrowing on adduction, as is typical in Duane syndrome, upshoot or downshoot in adduction, and abnormalities of the radial bone, artery, and thumb. In most cases that you will see clinically, there has been orthopedic reconstruction of the hand to create a thumb, but the radial arterial pulse is usually absent and the fingers are typically abnormal. Sometimes the radial bone is entirely missing in one or both upper extremities. And as Mary told you, this is due to a dominant mutation in the SAL4 gene on chromosome 20q13. It's a zinc finger transcription factor, but Mary told you all about that. So in this case of Duane's radial ray syndrome, we see on the right eye, we've got the findings in the right eye and in the left eye. And we see some direct evidence of misinnervation of the extraocular muscles. So these are very high resolution quasi-coronal images from posterior to anterior, going from top to bottom in the right and left orbit. We can identify here a direct continuity of the inferior division of the oculomotor nerve with the lateral rectus muscle, as well as the abducens nerve. So it appears that the lateral rectus is co-innervated both by the abducens and the oculomotor nerve. We can even follow the normal pattern of innervation of the inferior division of the oculomotor to the medial rectus muscle on both sides. In addition to those innervational abnormalities, we see hypoplasia of the lateral rectus muscle in the left orbit and a fissure demarcating the superior and inferior compartments of the lateral rectus muscle. In the brainstem, in this particular case, we see a rather normal right abducens nerve in the subarachnoid space at the pons, but a very dysplastic, meandering, and distorted left abducens nerve. In this case, with Duane's radial ray syndrome, we see a normal configuration and size of the subarachnoid oculomotor nerve at the level of the midbrain. Once again, the theme of subclinical optic nerve hypoplasia emerges. So here we see the typical average diameter of 17 normal oculomotor nerves, optic nerves, as imaged in the immediate retrobulbar space, about 4¼ millimeters. Duane syndrome type 2, down around 3.6 millimeters, and about 3.4 millimeters in Duane's radial ray syndrome. Yet, the effect on visual acuity is negligible, with normal visual acuity at about 0 logmar or 20/20 vision on average. So this aspect of the endophenotype is not clinically evident by Snellen acuity testing. Let me talk briefly about congenital fibrosis of the extraocular muscles. Very rarely is good histology done of these muscles, but this was prepared in my own laboratory using Masson's trichrome special staining, which stains collagen or tendon dark blue and the muscle fibers red. The inferior rectus muscle is typically most affected in congenital fibrosis type 1, and it is said that the muscle is replaced by fibrosis and doesn't have any contractile fibers. That's clearly incorrect. These are beautiful contractile fibers. Let me explain to you why that traditional teaching is not correct. Now, as Mary mentioned to you, congenital fibrosis type 1 is autosomal dominant, typically due to a single amino acid substitution in the developmental kinesin KIF21A, which is responsible for axonal transport in the developmental stage. Typically, in fact, by definition, in type 1, there is bilateral ptosis and restrictive hypotropia. The eyes are bound down and the lids are down. Patients will typically develop a chin-up ocular torticollis and have no levator function, and they're typically very exotropic. So here's a typical case that we looked at in adult life. The patient has a kind of lambda pattern. To the extent the patient can look up, the eyes become esotropic, but when looking down, there is an exotropia evident. Nearly all of the older patients have undergone some sort of lid procedure so that they can see, and it is going to be a frontalis suspension of some sort because there's no levator function. This is a sagittal view with T1 weighted MRI and gadodiamide contrast here, lighting up the choroid, showing you a patient who'd previously had a disinsertion of the inferior rectus muscle by another surgeon. So you can see the disinsertion here, both of the global and orbital layers with a small strand of connective tissue running toward the inferior oblique muscle. Note the profound hypoplasia of the superior rectus muscle and the levator seen here, and a relatively normal optic nerve in this individual. When we imaged the patient that I showed you for whom the photograph was illustrated, we see some interesting things going on. When the patient attempts to look up, nothing much happens vertically because of the profound hypoplasia of the superior rectus and levator. Just a tiny wisp is all that is present there. Notice the size, though, of the lateral rectus cross-section. When the patient looks downward, the lateral rectus muscle contracts vigorously. There is a miswiring, presumably of the inferior rectus motor branch of the inferior division of the oculomotor that activates the lateral rectus muscle during attempted infraversion. There is no function of the superior rectus to oppose that. Also, in downward gaze, the lateral rectus muscle shifts superiorly and encyclorotates, producing an encyclotorsion on an attempted downward gaze. So this explains the lambda pattern that the patient has. Finally, you see dysplasia of the lateral rectus muscle, which is more evident in this image of the same patient, where I used very high resolution imaging to trace the presumed entry of the inferior division of the oculomotor nerve into the inferior portion of the lateral rectus muscle, which you see here. We also see this little accessory portion of the lateral rectus muscle and the profound hypoplasia of the superior rectus and levator palpebrae superioris muscles. In this particular individual, we see profound hypoplasia of the subarachnoid oculomotor nerve. You can barely see it at all in this case here, in contrast with the normal one, which is seen on the left side. There is practically nothing to be seen there. I will yet again emphasize the evidence for the subclinical hypoplasia of the optic nerve. In 10 cases that I imaged, there were bilateral hypoplasia of the oculomotor nerve, of the optic nerve, and in 2 of 10 cases, unilaterally small optic nerves, as illustrated here in comparison with normal. That's T1 weighted MRI. Quantitatively, that amounts to the difference between an average of 14 millimeters squared of a normal cross-section versus about 8, and yet visual acuity is generally normal. Some additional abnormal findings are evident in congenital fibrosis type 1 occasionally. Supernumerary bands between the lateral and medial rectus muscle may be seen, sometimes unilaterally. You can see that in coronal imaging here, deep in the orbit, and that's seen again in sagittal imaging. These would not be readily accessible by surgery, and probably there's no indication for operating on them. To conclude, the external phenotype of patients with strabismus due to the congenital cranial dysinnervation disorders is not adequately reflective of the internal endophenotype. Some sort of imaging, preferably MRI, is required to fully characterize the endophenotype, and sometimes that's relevant and decisive in making a surgical decision in these patients. Thank you very much.
Thank you, Joe, for such a wonderful presentation. Again, beautiful slides, beautiful imaging. Fortunately, we don't always have access to those high-quality images, but I think this is very helpful to in terms of elucidating what's happening in these patients and unusual types of strabismus. So we're going to move on to the next speaker, Dr. Stacy Pineles. She's professor of ophthalmology, and she's a residency program director at the Stein Eye Institute at UCLA. She completed fellowships in pediatric ophthalmology and neuro-ophthalmology, and also has a master's degree in clinical investigation. Dr. Pineles has special interest in neuro-ophthalmic disorders, and she will be speaking on neuro-ophthalmic associations with congenital cranial dysnervation disorders. Welcome, Stacy.
Okay, I remember to unmute. Thank you, Hilda, and congratulations to Federico and also Dr. Kushner on such a amazing career over these past decades. I'm so honored to be here. Dr. Velez asked me to talk about neuro-ophthalmic associations with CCDDs. And I learned a lot in preparing this presentation. There's a little bit of overlap with the presentations that we've heard earlier, but I think in this complex topic, it's okay sometimes to hear things twice. I have no financial disclosure. So we all know by now that CCDDs are a group, a heterogeneous group of disorders that disturb ocular motility, usually bilateral, usually pretty serious. They account for about 5% of infantile onset strabismus, so not very common. And as we've learned this morning, the primary defect is an innervation with resultant fibrosis of the muscles. We've discussed a lot already about the neurological basis of CCDDs being related to neurogenesis and axon pathfinding. We know that during early development, the cranial nerves originate in specific brainstem nuclei, and then the axons are guided to their target muscles. Disruptions in axon guidance often involves different signaling molecules that we've discussed a lot already today that contribute to the pathophysiology of these diseases. Some of the key genes that have already been mentioned are KIF21A, PHOX2A, and TOB-B3. These disrupt neuronal development and connectivity, and then disinnervation from this results in structural abnormalities like fibrosis, which we've seen already, aberrant nerve pathways, and hypoplasia of cranial nerves. In the disorders we're talking about, the most common cranial nerves affected are obviously for us as ophthalmologists, we're interested in the 3rd, 4th, and 6th, and I'm going to discuss a little bit about the 7th as well. There's a complex interplay between the signals that are secreted in the embryonic signaling centers and transcription factors, which controls the development of specific cell identity. And we know that during hindbrain development, the homeobox genes help determine the segmentation of the hindbrain. And some of these mutations have been associated with Duane's. There are a lot of different gene mutations, many of which have already been covered, that have been identified in the process that cause the aberrant guidance and result in CCCDs. The diagnoses that I wanted to touch on today and relate some of the neuro-ophthalmic findings are listed here. And as I keep saying, we've discussed many of them already. Of course, CFEOM 1, 2, and 3 involving the 3rd nerve and in some cases the 4th and the 6th. Duane's involving the 6th, Mobius syndrome involving the 6th and the 7th, and horizontal gaze palsy with progressive scoliosis also affecting the 6th. So we'll talk about some of those. Starting with CFEOM, we've talked a lot about that already today, a developmental anomaly of the 3rd cranial nerve with 3 different sort of well-characterized subtypes. The more common ones are the autosomal dominant CFEOM 1 and 3. Both of which have ptosis, but CFEOM is much more symmetric and bilaterally symmetric, whereas CFEOM3 is quite variable and maybe unilateral. CFEOM2, less common with autosomal recessive inheritance, and frequently you see pupillary involvement, which you don't see as much in the other 2 types. Speaking about CFEOM1 first, we already know that it's associated with ptosis and fixed eyes and down gaze, not usually associated with other neurologic abnormalities, but there are several things that are seen on brain MRIs. We've mentioned already hypoplasia of the 3rd nerve nucleus and 3rd nerve, sometimes loss of the superior division completely and its corresponding motor neurons, abnormal innervation patterns in the orbit, and then, of course, atrophy of the superiorly innervated muscles. With CFEOM3, You frequently see restricted upgaze and ptosis, similar to CFEOM1, but less symmetric. There are more associated neurologic and neuro-ophthalmic conditions that are associated with CFEOM3, probably related to the differing genetic underlying pathogenesis. These patients tend to have more frequent other cranial nerve deficits, other cranial nerves outside of the third, fourth, and sixth. More frequently, these patients will have intellectual and social disabilities, more frequent brain malformations seen on MRI and causing developmental delays. And they also have been reported to have a progressive peripheral axonal neuropathy. So CFEOM3 is less common and less symmetric, but more frequently associated with several neurologic conditions. When you look at these patients, you, of course, on MRI see the hypoplasia of the third nerve, frequently seeing a thin optic nerve, as Dr. Demer mentioned. Misinnervation can be identified, and then hypoplasia of the extraocular muscles. As I said, there are a lot of different brain malformations that have been reported with CFEOM3. They're all listed here. I'm not going to go through all of them, but just don't be surprised if you have a patient with CFEOM3 if they have other structural abnormalities of the brain, and also cranial nerve 7 involvement. Some of the other syndromes that you see with CFEOM3 specifically are focal vocal cord paralysis, facial dysmorphism, and these are related to 7 and 8 9 cranial nerve palsies. Intellectual social disabilities, Kallman syndrome, which was mentioned already, sometimes joint contractures, gait abnormalities, and then less commonly cyclic vomiting. Another thing besides these structural brain and neurologic conditions that we see in patients with CFEOM is optic nerve findings. And this has been mentioned already by Dr. Demer, that optic nerve hypoplasia is frequently seen in CFEOM 1 and 3. Maybe in some papers, up to about a third of patients have clinical or subclinical optic nerve disease. It can be a frank hypoplasia, or it can be a disc excavation and thinner rims that you see on OCT. Another interesting thing besides the optic nerve findings that we all sort of know about and have discussed are retinal dysfunctions. Retinal dysfunction has been described in small case series of patients with CFEOM2. Again, CFEOM2 is less common, but when you see it, you can expect to see some abnormalities in the rod and cone response on electroretinogram. There was a paper by Kahn's group looking at 10 patients with CFEOM2. And these patients all had depressed responses for rod and cone, for rods on ERGs, and most of them also had abnormal responses for cones. All of these CFEOM2 patients had abnormal vision, and so that's why they underwent ERGs. So there are some CFEOM2 patients who have normal retinal function and, of course, normal optic nerves, but those who have subnormal visual acuity should be worked up for retinal and optic nerve disease. The authors of this particular paper suggested that orbital disinnervation itself or abnormalities in catecholamine function, which are important for retinal development, may explain the retinal dysfunction in these cases. Moving on from CFEOM, we've talked a bit about Duane syndrome today as well. I wanted to just mention some of the neurological and neuro-ophthalmic associations. We all know about Duane's and some of the associated syndromes that can occur in conjunction with Duane's. Most specifically, I wanted to mention Duane radial ray, Goldenhar, and then the HOX-A1 syndrome. Dr. Demer mentioned some of these, and these are all conditions that one needs to think about when they see patients with Duane's. Less commonly seen, but a little more interesting in terms of neurological associations, is Mobius syndrome. This very rare condition occurs when you have unilateral or bilateral 6th and 7th nerve palsies. And so the patients, of course, end up with facial weakness and restricted abduction. There's a sporadic form that is seen frequently due to brainstem ischemia, meaning that the 6th and 7th nerve part of the brainstem are ischemic, and so the patient gets an acquired Mobius syndrome, and this presents usually on MRI with focal necrosis of the vascular territory, of this vascular territory in the brainstem. But then there's also, of course, the non-ischemic that we think of as more common, the genetic condition. Usually patients present at birth with orofacial and lingual or pharyngeal dysfunction, and they frequently have limb malformations. They often have vagus nerve abnormalities, dysarthria, usually have abnormal coordination and hypotonia as well, not always. When you think about Mobius syndrome, of course, you think about the 6th and 7th nerve, but it's important to know that they can have variable involvement of other cranial nerves like 8, 9, 12, and that leads to some of the conditions that I mentioned, such as dysarthria and vagus nerve abnormalities. MRI of Mobius syndrome tends to reveal extraocular muscle hypoplasia, abnormal rectus muscle paths, and absence of the facial colliculus. Sometimes you also see a small internal auditory canal. Horizontal gaze palsy and progressive scoliosis is another CCDD, much less commonly seen. It's autosomal recessive, and it presents as 6th nerve horizontal gaze palsy in conjunction, of course, as the name says, with progressive scoliosis. So here's a patient who has progressive scoliosis and a horizontal gaze palsy. The scoliosis tends to occur later after the age of 2, so this isn't something you see from birth in terms of the back, but the eye findings are usually seen earlier. These patients do not have co-contraction like Duane syndrome because they don't usually have the 3rd nerve innervation like Duane syndrome patients. There are a few MRI findings that we see in these patients. There's typically a brainstem hypoplasia that results in a midline dorsal cleft, giving you a pons that kind of looks split, and a butterfly configuration of the medulla that you can see on axial images. Again, you have frequently absence of the facial colliculi as well. I wanted to spend the last 2 minutes talking about facial expression in patients and perception of facial expression as a neurologic association with some of these CCDDs. This isn't something that we think about much as ophthalmologists, but it really sort of does impact our patients. And that is that when babies are learning to understand facial expressions, there's some evidence to show that in order for them to understand facial expressions, they need to be able to make facial expressions. So when a baby is learning about happiness, for example, and they see their parents smile, when they're able to learn to smile, it helps them to understand that smiling means happiness. And so some of our patients, especially those with Mobius syndrome and other forms of facial nerve palsies that go along with CCDDs, have difficulty here. And I think it's interesting for us to understand. This is a research study that enrolled patients with Mobius syndrome who had strabismus and facial palsies and who were older and had normal intellectual function, and asked them to look at faces of people who had different emotions, happy, fearful, angry, and compared their understanding of the amount of happiness, fearfulness, and anger to people who had normal facial movements. So for example, in a control task, when you had controls and Mobius syndromes, when they were looking at body movements of happiness or fearfulness, the people with Mobius were able to understand those emotions. But when they were looking at faces, like you're seeing here, patients with Mobius syndrome were much less likely to be able to detect fearfulness on a picture of a face. Same with anger and a little bit with happiness. So it's just sort of an interesting kind of neuro-ophthalmic kind of perceptual thing that some of our patients may be experiencing. And when our patients with Mobius syndrome see a person do body movements of an emotion, they can interpret it normally. But when they see a facial movement that portrays happiness, fearfulness, or anger, they may not understand it as well. And this can lead to difficult social interactions for these patients that we may want to at least try to understand and sometimes convey to the families, because there can be misdiagnoses of autism in the worst cases here when it's not clear to families that patients just aren't understanding the emotions. Anyway, just something to think about in some of these CCDDs. So in conclusion, this is a very diverse group of disorders. In terms of neurologic and neuro-ophthalmic association, we can see congenital brain malformations frequently, as well as retinal and optic nerve abnormalities. And keep in mind that the inability to move the face in a normal way may affect perception of emotions in our patients. So thank you very much, and thanks for including me, and looking forward to our last couple talks.
Thank you, Stacy. That was super interesting. So now we have covered the genetics, we have covered the imaging, and we have covered neuro-ophthalmic disorders associated with CCCDs. So how do we treat these problems? Well, David Hunter, who is ophthalmologist in chief and the Richard Roth Chair of Ophthalmology at Boston Children's Hospital. He's also president of the Children's Hospital Ophthalmology Foundation and professor and vice chair of ophthalmology at the Harvard Medical School. He will be talking to us about strabismus surgery for patients with congenital cranial dysnervation disorders. Welcome, David.
Well, thank you so much for having me, and for the invitation from you, from Dr. Velez, and of course, Dr. Kushner, who's been my mentor from afar for all of my career. So I'm honored and happy to be a part of this. So I will share the wrong thing. So I'm going to change my share. Share the right thing. There we go. All right. So yes, I'm going to be talking about a difficult topic, which is how to do strabismus surgery in these patients. So I will, you know, the CCDDs, you've heard about them. I'm just going to focus on CFEOM because there's just not enough time to get into all of them. You know, maybe some of these comments apply to the other motility syndromes, but not to the ptosis, obviously. I did want to make a point that you hear about orbital bands, and while they are present in CFEOM, there are also conditions of congenital enophthalmos with orbital bands that is not a CCDD. The neural innervation is probably okay in those patients. So, and those patients are handled differently than the CFEOM patients because of those orbital bands. So let's talk then about this management. I'm not the first. In fact, Mike Brodsky published this really helpful review back in 1997 that I have continued to use. And in that review, he proposed 8 principles of strabismus surgery in CFEOM, all of which I've continued to find very helpful. So these are that undercorrection is the rule, as you will see. Consider free tenotomies as primary treatment, which is may sound radical, but I'll just say that these patients, you basically, you know, to summarize in advance, you throw out everything you know about doing surgeries for strabismus in these patients. The expectations are different, the treatment is different, and the results are, the outcomes are different. Resections are frequently necessary. We don't use them much in Duane syndrome, some, but often need them for the horizontal deviations in these patients. Vertical rectus muscle surgery changes horizontal alignment. That's right. I'll show you examples of that. Intraoperative examination is helpful to characterize these patients. Beware of large post-op A patterns. Joe Demer alluded to that, the dysnervation that causes A patterns commonly. Symmetrical surgery may have an asymmetrical effect, go figure, but it does happen. And then look for fibrosis within the orbital fascia and check ligaments, as Joe Demer showed in MRI scanning. In the 25 years since that was published, and especially in the last 20 years that I've been operating on a fair number of these patients, thanks to my collaboration with Elizabeth Engel, who has attracted these patients to Boston for research studies, I've come up with 8 more principles. Well, that was the citation of that one. 8 additional principles based on what I see coming in from outside and what I've done. So one is that binocular vision is not the goal in these patients. So you know, you don't have to like rush into surgery to try to preserve their binocularity. It's just not going to happen. So, you know, be sure you know what you want to do and have all the data you need before you start operating. Second is surgery in adults has less impact. Although binocular vision isn't the goal and you don't have to go super early, it does have less impact and more risk in older adults. Third is that MRI imaging, as Joe Demer said, can change management and does, and really should be performed on any patient before you operate on them. Next is that genetic testing can reinforce, with some exceptions, genetic testing can, I'll say, reinforce the treatment plan, and I'll show you how I've incorporated it into my thoughts. It's not a must, but it's I found it helpful. Next is expect the superior oblique muscles to be abnormal in these patients. I'll show you examples of that. We're up to the sixth is that conservative ptosis management should follow or perhaps be simultaneous with strabismus surgery, but not happen before strabismus surgery. The seventh is try to avoid causing lower lid retraction with these big recessions, especially in adults. And the eighth is that a small residual chin-up position, even though you may not have much control over where the patient's head posture is probably optimal for these patients because they still need to read and they need to walk and their eyes don't move. So what I want to do now is to show you 10 cases to document these 16 principles in the next about 10 minutes. And these are to show some of the successes and some of the failures in my practice in trying to treat these patients. So first is a patient who came to me a long time ago when I first started seeing these patients. He was 7.5 by the time he got to me, but he was presented at 4 months of age, had dyskinetic eye movements. First surgery, inferior rectus recessions, basically did nothing. Z myotomies also did nothing. He had lateral rectus recessions, also did nothing. He had superior oblique tenotomies. That started to help with his head position according to history. And then he had repeat inferior rectus recessions. And that finally got his vertical alignment in a pretty good place and his head position in a pretty good place, though he remained exotropic in primary gaze, but shows that esotropy and attempted up gaze that all the patients. Oh, and I am going to show, when I have the genetics, I'll put it up here. This is a KIF21A, so one of the CFEO1 patients, somewhat unusual variant N947T. So anyway, I won't go further into the management of exotropia because I have other cases for that, but he demonstrates the concepts of binocular vision is not the goal and undercorrection is the rule. So that is case one. Case two, this is also the first several are going to be KIF21A patients. This is the more common R954W variant. He's 63. He said, I'm tired of staring at my nose all the time. But what really pushed him to surgery is that his cataract surgery can't get to the lens of his right eye to do the surgery. So I did bilateral medial rectus recessions, 8 millimeters, bilateral superior oblique tenotomies, and 13 millimeter hangback. So you can argue where the inferior rectus muscle ended up, but 13 millimeter bilateral inferior rectus recessions. So here he is. That's post-op. Now, at first you might wonder, is that post-op? But the head position is better. He likes that. And his eyes are straighter. So he was able to have his cataract surgery. So he's not staring at his nose all the time. So he's better. And he was pleased that he had had this procedure. And you'll note that even though I did a huge amount of surgery, we still didn't get the eyes up all that very high. So this demonstrates, again, undercorrection is the rule. And in my experience, surgery in adults has less impact than surgery in childhood, probably because of some of the change in the orbital, the orbital tissues that happen over decades. Then his daughter comes in, so same variant, 40-year-old woman. She'd already had 9 millimeter inferior rectus recessions and an 8 millimeter right medial rectus recession. She's got neck problems. She's uncomfortable. This is how she fixates, primarily with her right eye and her ptosis. So when she's walking around most of her life, she's looking at that. She wants to see if more can be done to get her head a little bit straighter. So she demonstrates the principles. Undercorrection is the rule. So what did I do? In this case, a right medial rectus tenotomy. Well, that's right. Bilateral superior oblique tenectomies, and then both inferior rectus muscles, I found them, and I sutured them to the lateral inferior orbital rim to try to get the eye to come up. So what did we get? Well, actually, also she demonstrates the concepts, consider free tenotomies or as on the medial, or profound weakening as primary treatment. So post-op, what we got is right eye, pretty good place. But actually now her neck hurts because she's not used to holding it straight. And it took her like months or maybe a year before the neck pain improved. Also, she developed a corneal ulcer in her right eye, which was basically her only seeing eye. So there was a bit of a fire alarm treating that. We were able to successfully treat it, but you see the lower lid retraction that developed with that significant inferior rectus surgery. And perhaps if I had got hold of the lower lid retractors, I could have managed that a little bit better. Also, could not get the left eye to come up. There were orbital bands back there, most likely. It's an old case now, so I have to go back to the imaging, but I couldn't get the left eye to come up despite doing the same surgery on both eyes. So she demonstrates surgery in adults has less impact and more risks, that to avoid causing lower lid retraction and to look for fibrosis within the orbital fascia. Case 4, 7-year-old, again, KIF21A R954W. She's got a chin-up head posture, a little bit of an XT, nothing too profound. But in her case, the MRIs showed less severe attenuation of the superior rectus muscle than what Joe Demer showed in his classic case, where there was just a little thin nothing up there. And so I decided not to touch to the combined effect. I didn't touch the superior oblique tendons, which I usually do now in these cases. And I put these 11 millimeter recessions on an adjustable suture. And so I got a pretty good effect. So this demonstrates that MRI imaging can change management. So I got a pretty good effect on the head position, but surprise, new large exotropia and diplopia. So now she's holding her head straighter and she's seeing double because she's got this huge XT. So this is related to the changes in tonus, because remember, in down gaze, the patients were exotropic, right? So and when you release, so there's this constant tonus to try to pull the eyes up, and that's probably pulling the eyes in or maybe relaxing the lateral cross-wired lateral rectus muscle. So whatever, I can wave my hands, but here it is, you've got this XT. So this demonstrates vertical rectus muscle surgery changes horizontal alignment. So what did I do? I did bilateral lateral rectus recessions. This is before I had read, I guess, Brodsky's paper about that you should do resections. That does nothing. 12 mil, again, they're hangbacks. Maybe they didn't go 12 millimeters back, but no effect, basically. So procedure 3, I now went back, put the laterals back further and resected the medials 10 millimeters and finally got rid of her double vision and got her eyes reasonably straight. So that demonstrates that resections are frequently necessary in these patients. That was about 4 years out. Case 5, we're still in KIF21A. Now we're at, this is another M947T. So this is a boy adopted from China at age 3. He had crossed eyes and ptosis. He'd had surgery elsewhere. Inferior rectus muscles were tight. They just injected them with Botox, though. And then he had bilateral frontalis slings, but no real strabismus surgery. So then those were revised and then they were removed because he had corneal exposure and scarring. So that demonstrates ptosis management should follow or at least be simultaneous with strabismus surgery. The family was told that nothing more could be done, but he came for another opinion. I mean, here he is with this large esotropia, increases in up gaze and lateral gaze, somewhat smaller in down gaze. So what to do for him? Well, at surgery, the inferior rectus muscles were tight. I could get him up to the midline. The medials were very tight, could get the eye about to the midline. Superior lateral and inferior oblique muscles actually had relatively normal tension, but his superior oblique tendons had anomalous insertions. I'll show a picture of that in a minute. So I did medial rectus, big recessions, inferior rectus, just big recessions, superior oblique tenotomies, and then Alexa Elliott came in and put in silicone rods for a gentle lift of both eyelids to correspond with, as best we could tell, the effect of the surgery. So it demonstrates the concept intraoperative examination is helpful. This is this is right eye surgeon's view. That's the superior rectus muscle under a hook. And then what's this? Nasal to the superior rectus. Oh, it's the superior oblique attached to the eye, nasal to superior rectus. Not knowing what else to do, I cut it in this case. So what did we get? We get, that's just the still image of that. Well, actually, we looked back then and said, you know, I've seen this before. So we look back at all of the patients I've taken care of, and at least in our patients, 93% had some superior oblique abnormality. They weren't all anomalous insertions. Some of them were just very tight superior oblique muscles, but you almost can expect it, or at least have a high degree of suspicion superior oblique is going to be in the wrong place in these patients. Talia Shoshani was a medical student who helped me with that study. So how did our patient do? You know, he's looking pretty good. His eyes are straight. He's a little overcorrected on the horizontal, but you know, his laterals maybe don't work so well, so I'm not too worried about that. Wasn't happy to see that lower lid retraction, and indeed he had an irregular corneal surface, some surface problems for a while. Eyes basically don't move now, but they're reasonably straight. But within a couple of months, I only have a virtual visit because he traveled. But the family was very pleased. You see, he's got to a residual chin up. The lid retraction isn't too bad. Maybe a small residual esotropia in there. Certainly not overcorrected. So this demonstrates a few things. Expect the superior oblique muscles to be abnormal. Conservative ptosis management should follow or be combined with strabismus surgery. And a small residual chin-up head posture is probably a good thing for these patients. The next patient, catch your breath here. This one, the family wasn't ready to have genetic testing, but there was a strong family history, maternal grandmother, mother, maternal aunt, and sister. It was only females in the family are affected. Diagnosed with CFOM at age 14 months. Chin up, large left exotropia, as you see here. And you see the left eye does not move very well to the right, whereas the right eye moves to the right and to the left. On imaging, you see that this left medial rectus muscle looks smaller than the right medial rectus muscle. Superior obliques are kind of maybe bigger. But there was more to the superior rectus muscles than I usually see. But she did have a chin-up head posture, and I was worried that inferior rectus recessions alone wouldn't do it. And so, based on the MRI findings and the clinical findings, I did do smaller, I did smaller inferior rectus recessions. I did big surgery. I did bigger surgery on the left lateral. So I reduced the surgery. I still did the bilateral superior oblique tenotomies, but just 4 millimeter inferior rectus recessions. And their left lateral was super tight, so I did a myectomy on that side. The right lateral, I just recessed to sort of balance things out. So this demonstrates MRI imaging can change the management. Genetic testing can reinforce the treatment plan. In that, I didn't have genetic testing, so I felt less confident about my treatment plan because this wasn't your basic R954W KIF21A patient. Consider free tenotomies and intraoperative evaluation can be helpful. So I didn't get what I wanted though. Post-op day 2, she's overcorrected. She's using her thumb to hold her eyelid open. But it's not just a matter of ptosis, because when she does it, she needs a chin down posture, and she's got a right head turn on the side where I just recessed the lateral that the eye used to move well. And she's got a left hypertropia. So we went back to the OR the next day. I advanced both inferior rectus muscles to the insertion. I advanced the right lateral to the original insertion. And this is still an active case. So I don't know. I mean, last I heard, now her head position's better. She's able to see without lifting her eyelid. But the left eye is still higher. So every rule has an exception. And this is an example of that. But she does demonstrate symmetrical surgery may have an asymmetrical effect, and a small residual chin up head position is probably optimal in these ptosis patients. How am I doing? So we've got 3 cases in 3 minutes. A 1.5-year-old boy with bilateral adduction limitation. He's got he's a TUB3 E410K. You've heard a lot about those. I did bilateral 14 millimeter, big bilateral lateral rectus recession, big inferior rectus recession. This was a long time ago. One of the first patients I treated. We were all, high fives. right after surgery, his eyes are straight, but within a month, he's back to XT. Tried to weaken the lateral rectus 2 more times. He remained exotropic. He's now like 16 years old. He doesn't want any more surgery. So under correction is the rule. Consider free tenotomies or myectomies as primary treatment, and resections, I would do that now, or transposition. I'm going to feel like I'm running a little bit too late, too long, so I'm going to skip this one patient, except to say I did do resections on him of the medials, and he looked horrible on day 1, but this one I let go, and he settled out. And then case 10. So finally, an 18-month-old girl, I think this is the last one, noted to have abnormal eye movements, ptosis at age 3 months. Genetic testing, she's at E410K. So ptosis repair was recommended, but the family read about corneal problems and they declined it, which I think was a good idea. I didn't want Joe to Demer to see the poor quality MRI, but the medial rectus muscles were attenuated. But you know, MRIs are like, it's like pizza. Even bad pizza is still better than no pizza. So as long as you want something. So we want to manage the ptosis following strabismus surgery. So I did a big R&R on the right side because that eye had a little bit more movement, and transposed them both up just to treat a little bit of the head posture. And then I did a full, cut both the obliques and a nasal transposition of the split lateral rectus muscle to pull that left eye in. We just did a baby, almost nothing ptosis surgery just to get her eyes this much open. And we're talking about doing more. So she demonstrates, consider free tenotomies or transpositions. MRI imaging can change management. Expect the superior oblique muscles to be abnormal, and conservative ptosis management. So to summarize, basic principles: operate before adulthood with bold weakening of tight muscles. Beware of surprise exotropia after vertical surgery. Use strengthening or transposition procedures when feasible. KIF 21A patients, you need profound weakening of inferior rectus muscles and superior oblique tenotomies. TUB 3 patients, you need profound lateral rectus weakening and moderate medial rectus strengthening. Need pre-op MRI. So consider these 16 principles, the checklist that you should go through before operating on one of these patients. 8 from Mike Brodsky, 8 more from me. If you check that whole list, then you might at least get a reasonable outcome and some improved function. I want to thank all of these individuals who have helped make this presentation possible. Thank you again for having me.
Okay, thank you for sharing all those cases, Dr. Hunter. Really fascinating. So we're going to move on to our keynote speaker. So it is an honor to introduce, let me see if I can show his slide here. Okay. It's going to... It is an honor to introduce our Dr. Federico Velez, a 2025 Kushner Medal recipient. He is a Leonard App Endowed Chair in Pediatric Ophthalmology at UCLA and Professor of Clinical Ophthalmology at the Stein and Doheny Eye Institutes. So Dr. Velez was born in Colombia. He's the son of a pediatric ophthalmologist, so it was in his genes. He did his residency in Colombia and then moved to Los Angeles to do fellowship training at UCLA, and joined the UCLA faculty in 2001. He has been at UCLA most of his career, except for a hiatus when he was part of the faculty at Duke. He's a prolific writer with over 250 publications and has delivered over 500 national and international lectures, including 6 named lectures, 51 keynote presentations. He's an exceptional surgeon and has developed innovative surgical techniques to address complex strabismus cases. Not only is he an outstanding physician, researcher, and educator, but he's also a great friend to many of us. So I would like to congratulate Federico on his well-deserved recognition for his exceptional contributions to the field. So welcome, Federico. Federico will be speaking on Duane syndrome, surgical approach to a complex condition.
Good morning. Let me see. I want to share here. Perfect. Okay. Good morning. I want to thank all of you for being here for me today. It's been an honor, and I don't have any disclosures. I really want to thank Dr. Kushner, the University of Wisconsin-Madison, and AAPOS for the opportunity to present this lecture in honor of Dr. Kushner and to be among the panelists today who I've learned so much through my career. So I appreciate very much everything you're doing here to be for me today. So a few words about Dr. Kushner. It's really one of those people I look after. He's an amazing leader, innovator. It is an incredible thinker, great mentor, and a wonderful friend. So I want to thank you so much for everything you do for me. You're always there, not only for my academic career, but also my personal career. So thank you, Burt, for everything you've done for me. I think among all the publications, this is one of the publications of Burt that I enjoy the most because he's really incredible collection of difficult cases, and he gathered expert in the field to comment, and it's really wonderful to read. So I was lucky to get a copy of it. I think Burt left us a great legacy at AAPOS with the Journal of AAPOS, and this is really the very first paper published in the new Journal of AAPOS back in 1997. So this is issue 1, volume 1, page 1. So thank you, Burt. I actually learned of Dr. Kushner back when I was in Colombia. One day I was looking at something for my father, and I found this picture, and I really needed to ask what's going on here. So here is Dr. Kushner. I assume this is in Brazil, so I assume he's south there because of the winter in Wisconsin. But it's really interesting how he gathered with these expert strabismologists in Brazil for an entire week. And I think they were sailing, and I'm sure eating great food. But I learned from one of the people depicted on this picture that they were really speaking on strabismus for an entire week. And that person even told me that even in the night, Dr. Kushner does not stop talking about strabismus. And this is actually my first encounter with Dr. Kushner. This was my first AAPOS meeting back in 1999 in Toronto. And I just met him and said, I want to take a picture with you. Would you mind? And the new book, Rosenbaum, just came out, and I asked him to give me a signature. So thank you, Burt. So what I'm going to present today is what has been my career on Duane syndrome and what I have learned along my way, and that's what I'm going to try to share with you. I mean, when we treat patients with Duane syndrome, we can just look for what is the primary position. But to me, that's not really enough. You can recess the medial rectus, you can recess the lateral rectus, you can recess both horizontal muscles, but at the very end, we may end with an eye that is not moving. And I think that this is something that we all have seen. Patients in whom we recess the medial rectus muscles for Duane, they have great alignment in the primary position, but there is a really significant lack of adduction rotation. And at the very end, this patient probably has a much more larger limitation in the binocular field of peripheral vision binocularly. And there are reports that demonstrate that about 70% of patients in whom the medial rectus muscle is recessed will have limitation to adduction that can be even worse for adults with sensory adaptation that may result in diplopia. So when I came to UCLA to do my fellowship, Dr. Rosenbaum was actually working really hard in convince people that transposition surgery was the way to treat Duane syndrome. And it was really interesting because I have my second paper. My first paper was actually with Dr. Demer on facial asymmetry, but this was my second publication, and it was on Duane syndrome, doing transposition surgery, and just to compare the results between a regular transposition and the new transposition augmented by a posterior fixation suture, because the year before, Dr. Foster has actually published his paper in the Journal of AAPOS in 1997 on the posterior fixation suture. So we just compared a group of patients in whom patients were treated with transposition surgery. Now this is the augmented transposition, was basically the biggest innovation for me when I came to do my fellowship in terms of transposition surgery. And we knew that this posterior fixation suture enhanced the transposition, increased the vectorial force, and perhaps created some adduction correction in the primary position up to 10 prism diopters. And basically, we found that compared to the regular transposition, this augmented transposition had a much better effect. And the binocular field of vision was enlarged, so we were all happy. But there were some patients who actually did not improve completely with the transposition because the medial rectus muscle was still significantly tight, so some patients required a medial rectus recession. So I was lucky to start working with Stacy on some projects, and there were two projects that we did together. And this was right after Dr. Rosenbaum had passed, but we looked at all the records of his previous operations, and we found out that one of the biggest factors in determining if the patient would require a medial rectus recession after a vertical rectus transposition was the force duction test. And how tight the force duction test and how soon from the midline we found the restriction would determine when we needed to do the medial rectus muscle. And I want to kind of come to this graph, which came out of Smith-Catterwell, and there have been some other publications, including one from Dr. Demer in 2007, on the length tension curve. And this yellow line depicts the medial rectus muscle in patients with Duane syndrome. Here you can see a patient with infantile isotropia where there is an increased tension even from the before the midline, but it's kind of a steady, very similar to the normal medial rectus. But in Duane syndrome, you get to a point where the medial rectus becomes very stiff, and then you get to the maximum amount of restriction to abduction. And if this is too close to the midline, then you will probably need to recess the muscle. But if it's really far in abduction, it's better to be away from that. Why is that? Because when you recess the medial rectus muscle and you don't have enough isotropia in adduction, or your force duction test is not that positive, then you may end with a problem, which is an overcorrection. And that was a second project that we did with Stacy, and how, prevent exotropia in patients undergoing vertical rectus muscle transposition. And I've been really interested on this because I have received a lot of patients who actually had previous vertical rectus transposition or even just medial rectus recession who ended on having an exotropic deviation like the patient on here, and they have lack of adduction, and the decision was to advance the medial rectus. And I want to bring this slide kind of off the topic, but I want to mention that advancing the medial rectus muscle in a patient that had a chronic overcorrection may actually worsen your patient. As you can see here, the advancement of the medial rectus resulted in a much larger abduction or exotropia. And the reason for that is that there is fixation duress. If you advance the medial rectus against the lateral rectus that is now tight, or if there was a transposition and the transposition is tight, the medial rectus muscle is trying really hard to adduct the eye. And the harder it tries, then the more misinnervation to the lateral rectus goes, and the more exotropia you will see. So I advise you to always look for what is holding your eye in abduction, like this patient, for example, that was overcorrected after a vertical rectus muscle transposition. But what's really interesting is that when I went in thinking that I needed to recess the transposition procedure, I found that the lateral rectus muscle was very tight. And all I did was an advancement of the medial with a recession of the lateral rectus muscle, and the patient turned to be in a very good alignment position with relatively good horizontal rotations. Vertical rectus transposition may cause vertical deviations. And there have been two publications recent, one from us at UCLA, we found about 8.5%, and one from the group of Boston led by Dr. Hunter and Dr. Daggy, they found 7%. What is really interesting is this information that came from a paper also from Dr. Hunter, and is that actually a lot of patients have inattentive abduction and down, like a depression, like a down shoot or something like a hypotropia. And this is important because these are the patients that have more limitation to abduction. But they found out that the patients that actually have a hypertropia, magnitude-wise, will have a much worse deviation. Why is this important? Well, because we usually don't measure patients in abduction, but you may predict perhaps patients that will develop a vertical misalignment by trying to measure them in abduction position. Then we moved to superior rectus transposition because we were too afraid that, we were creating a vertical misalignment when we were doing both vertical rectus, and second, because a lot of patients need to recess the ipsilateral and medial rectus to obtain a good result. And the reality is that the group of Dr. Hunter published that you can correct with a medial rectus recession plus superior rectus transposition up to 30% diopter of esotropia. And two papers, one from us at UCLA and one from them, demonstrated that the induced intorsion is rarely symptomatic, but it can cause symptoms. And when it happened, it's really hard to fix. I have patients in whom I have to reverse the entire surgical procedure because of a significant intorsion. The other thing that they found, Dr. Hunter group, was that in patients who develop the vertical misalignment, you actually have a high incidence of an increased vertical shift after a superior rectus muscle transposition, going from 19% to 45%. Why is this important? Because when I have a hypertropia preoperatively, I personally prefer to do an inferior rectus muscle transposition, something that I have the opportunity to also publish with Dr. Pineles. What about lateral rectus resection? This is something that we usually don't do for patients with Duane syndrome, but it's been published, and Jair Morad had a paper back in 2001 where they compare R&R versus bilateral medial rectus resection, and the reality is that the patient with the R&R did quite well. This is a patient recently published by Fernando Prieto Diaz in a Latin American journal, and this patient is a patient who never had surgery before, and he did a primarily recessed reset procedure. And I'm going to just present you a patient that I operated about a year ago. He had previous medial rectus recessions in this eye twice, and he still has an esotropia that recurred with a significant face turn. And I was afraid of doing a transposition surgery. We didn't really want to touch the other eye because the problem was that this medial rectus muscle was still pulling inward per the patient. So the decision here was to do a lateral rectus resection. And sorry about the picture that you see on your right side of the screen. They're pixelated because that was part of a telehealth visit, but this is to show you the entire story. This is the preoperative adduction rotation, day 1, and this is 3 months later, 6 months later, excuse me. This is the second one, great alignment in the primary position. And the last one is, you will see how much improvement in abduction this procedure gave this patient without really causing significant limitation to adduction rotation. So this is something to keep in mind that you can do. What about patients with exotropic Duane syndrome? And we're going to the next topic, which I think is going to be more interesting. So the exotropic patients, I always feel like doing a Y split with or without recession, depending on the primary position, is a great procedure. Again, with Dr. Pineles, we had an opportunity to publish this paper back in 2012. We did our Y split. My preferred choice, regardless of how much exotropia has the patient in the primary position, is always to do about 10 millimeter recession with a 10 millimeter separation of both halves, and then I just secured them on the sclera. I've done this procedure on an adjustable suture in some patients, and I'm going to present actually one in a minute that I did that. And it's a great procedure, but this is really important. Even if you improve the primary position, the patients still have a significant limitation to adduction rotation. Why is this important? Because I still think that there are patients with exo-Duane syndrome in whom either a medial rectus resection or a medial transposition of the vertical rectus muscle is needed to correct the horizontal alignment. This is a patient who actually underwent a lateral rectus muscle Y split for a right eye exo-Duane syndrome, and we did this procedure on an adjustable suture and the postoperative alignment. The patient had great alignment in the primary position, some deficient abduction rotation, and I want to call this attention to go to the next topic, but marked improvement in adduction, and the patient was happy. But what happened when the patients had limited adduction and abduction? And this is really a topic that I first learned by listening to Dr. Jampolsky, who really didn't like transposition surgeries for Duane syndrome. But he said, if you want to treat a Duane syndrome, just get rid of the lateral rectus muscle that is your problem and treat the patient as a 6-nerve palsy. When you have a patient that has an eye that doesn't move in or out, you have to look for several things. One, is this just misinnervation? Second, is that the patient may have some bands that are holding the eye from moving. Or third, how tight is the medial rectus, as we mentioned. So back in 2004, Dr. Rosenbaum did his first combined procedure to treat one of these patients. So basically, he was a patient who underwent a partial tecton augmented vertical rectus muscle transposition. The lateral rectus muscle was sold to the orbital wall, and later initially the patient has Botox to the medial rectus, but later the patient underwent the medial rectus muscle recession. And the patient actually started with this very small binocular field of vision. And after that, it was enlarged, and the patient was happy, and we were very happy. And we just have a few more patients, but I kind of stopped doing this procedure. I felt like it was too much for the patient. I probably was insecure that was kind of something that I wanted to do myself. But then I was forced to do it myself, and I said, well, what I can do. So I have the opportunity to work with some of my former fellows at Duke and also with Dr. Pineles on this paper that we just presented at AAPOS last year. And it's basically how to manage these patients. What can we do to improve A deduction and A abduction? So this is a patient that actually had orthotropy in the primary position, but the parents were very concerned with this exotropy and A deduction, esotropy and abduction, and they decided to proceed, even though my concern of creating a horizontal misalignment in the primary position, but the surgery went quite well. We did a recession of the lateral rectus to improve the A deduction, and we did a superior rectus muscle transposition, and the patient turned to be really in good position. Parents were happy, and I was happy. This is a much more complex patient of a patient that had a big downshoot and upshoot, limitation to A deduction, and esotropia in the primary position. This patient was esotropic. It was very unusual for a patient having this much of glove retraction and co-contraction. But anyway, so what I did on this patient, with the help of the fellows back then, we did this procedure. We did a lateral rectus muscle wide split recession, and perhaps just the recession would have worked well, but that's what we did. And then at the same time, we did a belly transposition type of Nishida transposition to basically where the lateral rectus muscle was. And I'm going to present you the ocular rotations post-operatively. There was a marked improvement on the patient's ocular rotations in A deduction. There was still a mild upshoot, but the esotropia was resolved in the primary position with some improvement in the ocular rotations. This is another patient, in this case with an exotropy in the primary position, severe limitation to A deduction, and limitation to abduction. So what we did in surgery, and the patient also had a big vertical misalignment, we found these fibrous bands that we actually excised, and then we did a split lateral rectus muscle recession, inferior oblique recession, because I think that there is still some patients in Duane syndrome that will actually need to have an inferior oblique muscle recession for the treatment of the upshoots, and that's been published. And because the patient had a hypertropia, I decided to do an inferior rectus muscle temporal transposition, and this is the outcome of the patient: great alignment, marked improvement in A deduction rotation, some limitation to abduction, but the patient turned to be in a good position with parents being happy. So we put this series of patients together, and I just want to tell you that the results were pretty good in general. It's a small series that we presented at AAPOS, as I said, and patients turned to be in good alignment in the primary position, and only one patient had a worsening of the abduction rotation after the transposition surgery. Another condition, synergistic divergence, a much more severe condition that we always consider that happen either when you recess the medial or when you actually have very severe co-contraction. However, there's been more than just that. So we put this series of patients with synergistic divergence back in 2021. We presented at AAPOS, and I'm going to present one patient that actually has, and I appreciate Dr. Demer and Mary that presented the previous slides, because, and Stacy that also mentioned about the hypoplastic of the cranial nerve 3, because this patient actually has a medial rectus muscle that is affected on the eye that has the synergistic divergence, which is very interesting because the patient was able to A deduct some, but the misinnervation kicked in, and then the eye went just out for that synergistic divergence. This patient was really interesting because I found that had multiple fibrous bands, very posterior, as far as 20 millimeters posterior to the limbus. So finally, I needed to do a medial transposition of both vertical rectus muscles to obtain a good alignment, because the two previous surgeries did not work despite of the large recession of the lateral rectus. So this is when you, and I think, may consider doing a medial rectus muscle either resection that I didn't do here because that muscle was hypoplastic, or a medial transposition surgery. This is another very interesting patient that has the same. He had a synergistic divergence, large angle exotropia in the primary position with limited A deduction. And what we found, again, fibrous bands. We did a wide split recession in both lateral rectus muscles. and the patient 3 years later demonstrate actually great alignment in the primary position, some AB ducting rotation, and the patient does not have the synergistic divergence that we saw before. So why is this important? Well, we put this series of patients together and we found a pattern that for us was really interesting. All these patients were individuals that were recognized as males, and 4 of the 6 were actually no white patients. And there's been publications before. Arif Khan actually had this mutation in COL25A1, which actually can cause synergistic divergence, patients with Duane syndrome, and he presented 4 patients, he published 4 patients. Of those, the 2 with synergistic divergence and exotropia were males. And there is another publication also that he found that were not related to this mutation, but again, it can be in patients with synergistic divergence. And there is another publication, this is actually using Saversite, and they found that 5% of the patients with Duane may have synergistic divergence. Of those, 84% were recognized as male, and they have exotropia. So Dr. Khan sent a letter to the editor back in 2016, I think was maybe David Hunter. I don't know, maybe Bill Good, but one of the two. Anyway, so, and he actually said that there is a pattern that most of the patients with exotropic Duane syndrome with synergistic divergence is predisposed to be male. So finally, accessory bands. So in patients with accessory bands, these bands they were not really seen that often, but now it seems that it's becoming a hot topic when we're treating patients with cranial degeneration syndromes, congenital cranial degeneration syndromes, Duane's, etc. I mean, we're seeing these bands, and everybody's talking about Duane syndrome bands, and there is this publication by Sener recently from 3 years ago, where he found that 75% of patients with exo-Duane syndrome may have fibrous bands. Now, he saw these many because he works with the microscope intraoperatively. I don't know how many of those were really creating significant restriction. But whenever I see a patient that has this much of limitation to a deduction, this big upshoot like you see here, and this patient has negative forced duction test in elevation, I always look for these fibrous band. This patient actually have one laterally. Just by removing the band, all the ocular movements, or at least in a deduction, got improved. We have the opportunity with a group at UCLA, Dr. Glasgow and one of our fellows, Dr. Ali, Dr. Pineles, to look at these bands. And what we found is these bands are actually composed of fibrous tissue, collagen, and muscle. So that's kind of a final slide for my presentation today. So in summary, when we treat patients with Duane syndrome, it's not just the primary position. I think our goal, at least the goal that I want to propose, is that we try to improve the binocular field of vision. And instead of doing just the medial rectal resection, which is an easy procedure, which can actually result in a smaller binocular field of vision. Second, lateral rectus muscle weakening is very critical to improve everything about a deduction. Medial rectal recession only recommended if you really have a tight medial in the midline. You may result in a synergistic divergence, exotropia, etc. The lateral rectus muscle resection is something that we can use. I limit it to 3.5 millimeters. And I do superior rectus transposition or inferior rectus transposition, or both, if the patient doesn't have really significant limitation in the primary position that requires recessing the medial rectus muscle. And finally, for accessory bands, I always look for patients that have severe co-contraction, synergistic divergence, exo-Duane's, severe limitation to ocular rotations, and patients identified as boys, and when patients with Duane syndrome have the right eye involved, because I've seen that happening more often. I want to thank you all for having me here. It's such a great honor to present this lecture today. Thank you very much.
Well, Federico, that was absolutely fabulous. I can't believe this is the 10th year in this series, but your presentation, you have certainly jumped over the very high bar set by your 9 predecessors. And I'd also like to thank all the speakers, Doctors Whitman, Demer, Pineles, Hunter, for doing a great job. I certainly learned a lot personally from this webinar, and my thanks to Dr. Capó for moderating. I'm reminded when I was a resident, 1973, attending my first international meeting in ophthalmology, the retina surgeons talked about this exciting new thing in their field, vitrectomy. And the cataract surgeons talked about this exciting new thing, intraocular lenses. And the glaucoma people were talking about their excitement with drainage devices. And then the strabismologist on the program got up and said, you know, there's been nothing new in strabismus in the last 100 years. And I can say that today you have certainly shown that that is no longer the case. I want to just share my screen for a moment. Federico, as the 10th lecturer, it's my honor to give you the Kushner Medal. As seen here, on one side is this sculpted likeness, supposedly of me, and on the other side is the seal of the great University of Wisconsin. I'd also say I hope you wear it with pride and can tell you that of the 9 previous recipients, none of them have ever contracted COVID while wearing the medal. So it's protective. And an honorarium will be in the mail to you shortly. And I want to thank you all for your participation and for your attendance. And I'll turn this over to Dr. Capó.
Yeah, well, thank you all for these fantastic presentations and an amazing way to honor Dr. Kushner, who had a fantastic career and helped us so much in the strabismus field. So I'm going to start asking a few things to Dr. Demer because he announced that he may have to leave early. So we don't want to miss his comments. I wanted to ask you, Joe, you know, it's been a hot topic in this whole session about this accessory orbital bands. And you have been able to identify them in DOVS and CFUM by MRI imaging. Well, how often do you see them in patients that do not have CCDDs, just in regular type of strabismus?
We actually see the accessory bands in normal asymptomatic controls. Since I recruit those for UCLA, maybe about 1% of cases. They're very rarely significant to ocular motility, and the bands that I demonstrated in these cases are not. More problematic are patients who do not have congenital cranial disinnervation disorders, but have restrictive bands. This is a different form of fibrosis, actual primary fibrosis within the orbit. Those bands tend to be very posterior, very difficult to manage. They're in immediate proximity of the optic nerve, so accessing them surgically is dangerous, if not technically impossible. So while the bands may be present, my take on it is that the ones that I can see by MRI are seldom significant surgically. The ones that Federico sees are in a location where even high-quality MRI will not demonstrate them.
So where do you look for the bands, Federico, when you go and do your surgeries? On the whole panel, where you tend to find those bands?
Yeah. Every time I have a very big restriction to rotations, then I just look for them. And when I detach, for example, the lateral rectus, I always recommend repeating the force reduction test. You look for the indentation on the sclera, and I use a small hook, and I just start looking and looking and looking. It is very funny because a short story, when I was a fellow, Dr. Rosenbaum told me once, there is, Jan Polsky keeps talking about some accessory bands, and I've been in practice for 30 years, and I never seen one of them. And soon after, we have one patient with Duane syndrome, he saw one. I think they're common. For sure, they're over there. I think there's some patterns that are more frequent than others.
So maybe somebody else in the panel may want to comment. Do you see them more frequently associated with a specific muscle, lateral, rectus, medial, vertical?
Lateral.
Lateral?
And
how about you, David? Lateral as well?
And is that more common in exotropic DOVS than in esotropic DOVS too? Yeah. So I think that would fit.
And Joe, I wanted to ask you also, you mentioned you saw a case of a hypoplasia of a third cranial nerve in a Duane's, exotropic Duane's. Have you found that in other cases as well, or it was just that isolated case that was hypoplasia of the third nerve? Oh, you're muted. You're muted.
It's typical to see hypoplasia of the third cranial nerve in autosomal dominant Duane syndrome associated with mutation on chromosome 2. Typical.
Okay. And usually they're exotropic, isotropic, exo?
They may be either, well, if they've got hypoplasia of the third, they're going to be exotropic, yes.
Well, it's not a very common finding. And I know you mentioned also about the optic nerve hypoplasia, and I think Stacy talked about it and showed some cases. You do see the hypoplasia by imaging, but how frequently do we encounter it in the fundus exam?
Well, as I said, I did these studies of the MRI before widespread adoption of OCT. So it may well be, and probably is the case, that with OCT, one would demonstrate some thinning of the nerve fiber layer. But the average visual acuity in those cases was normal. And so I call it clinically insignificant at any rate because of the redundancy in optic nerve axons.
Could it be neuroglial tissue differences though somehow that that the same number of axons but less cushion, or is there just not enough in the optic nerve to say that?
Hypothetically, but I've actually never encountered any cases where you had a deficiency of glia in the nerve with a normal number of nerve fibers. Usually it's the contrary. You have fibrosis of an atrophic or damaged optic nerve that leads to a smaller size.
Federico, there's a question that says, what is your dose table for lateral rectus recession with wide split and upshoot exoduane?
For exoduanes?
For exoduanes with the upshoot, when you split it, what is your surgical dose for that you use?
Yeah. So I always do the same amount. I think in reality, I don't think that the dose is just like recessing a lateral rectus. You just need to get the lateral rectus as far as you can because you need to get really rid of the action. When we published the paper, there was a letter to the editor, and there was a group of people who actually dosed the amount of recession. But the reality is that even the results didn't prove that it's superior to just doing like as much as you can. So I've been using 10 millimeters like the standard. But if you can do more, I think it may even work better.
Even for small exotropias?
Even for the small exotropias, yes. The only ones that I don't recess, I just do a wide split, is if the patient has an orthotropy in the primary position and big upshoots.
Yeah. Do you ever use a recession of both medial and lateral for upshoots and downshoots?
Never. I don't want the eye to stop moving. I want the eye to move better.
Do you ever use them, David?
Well, I in some of these cases, what I've been favoring lately is I'll do a Y split if there's an upshoot and they tend to be, so say it's on the left side, they're exotropic and right gaze. So then I will I'll recess the lateral as many millimeters as I want to get further movement of the eye over. So if I just want to get like 3 more millimeters of adduction, I'll recess the lateral 3, and then I go to the other side and do the adjustable FOD and a combined resection and recession of the other lateral rectus on the other side to really try to get a significant limitation of abduction of the right eye, because I feel like you just can't get full adduction of the left eye. So rather than do recessing both muscles, I do Y split, move the muscle back as many millimeters as I kind of want to get. So I don't want to move the lateral too far and cripple abduction, because I've had some patients who they miss. They don't want to lose any abduction for sure, even though they're exotropia. So I move it as the least I can and then try to make up for it on the other eye.
I think transpositions are becoming much more and more popular for Duane syndrome. So I think Rosenbaum finally got his message through. It took a while, but we're there. And there's also, it's always difficult to decide when do we do superior rectus transposition, when do we do inferior rectus transposition. Again, there's some guidance. If you have a hypotropia, if you have a hypertropia, you may change your mind, or when do you use an Ishida procedure? because now that's becoming more popular. And I wonder if using Nishida will avoid the postoperative hypertropias and hypotropias that we frequently or we can see with just a one vertical rectus transposition. Any comments on that? You're muted, Federico.
I was saying, David, go ahead.
Well, so I've been not happy with the Nishida procedure, and I'm curious what Federico finds in Duane's syndrome. I had to take one down that was done elsewhere. I feel like, and I don't have any data on this, but it seems like, in Duane syndrome, the lateral is already tight. You're pulling these muscles over. The superior and inferior might be a little tight. So you end up getting, like, I've seen a few times, restricted supra and infraduction, to where the range of binocular single vision up and down becomes less, and the restriction of the eye isn't. You just I don't know. That's been my effect. And then I also had a question for Federico or Stacy too, or Mary. The few times I've done the inferior rectus transposition, it's been sort of like not quite what I was hoping to get. I just feel like I don't get the same effect and as with the superior rectus transposition.
Any comments on Nishida, Federico?
Well, the times that I've done the Nishida for Duane's have been patients in whom I, exactly what David said that he doesn't like, is basically that I get rid of the lateral rectus muscle, and then I do the transposition to improve the abduction in the primary position. So those are the patients that I have done it. But I don't like the Nishida as it's being described. I think, in my opinion, I still don't find the logic of why you need to put a suture in between the lateral rectus and the superior rectus. So whenever I do, I really put the posterior fixation suture, because in reality, it's a posterior fixation suture next to the lateral rectus muscle. I prefer to put it there because if I think you're going to get more movement of the vertical rectus muscles, and perhaps it will enhance the effect of the transposition surgery. I've been doing that for a long time. And with the Stacy, we actually did a project a long time ago, and we published that if you do something like that and you're concerned with the induced vertical deviation, just put the posterior fixation suture on an adjustable suture. You just create a small incision back there. I know Linda does the multiple posterior fixation sutures, and she start cutting them. But if you like adjustable sutures, you can just do one and just kind of release it in the recovery room.
Do you tend to get more hypertropias or hypotropias with superior rectus transposition? Because there was a paper published by the Boston group, so probably David can comment. And they found there were more hypotropias, which is kind of interesting. I was getting more hypertropias, and recently I got a hypotropia after a superior rectus transposition. So if you have no deviation, no vertical deviation to start with, do you see more hypers or hypos with a superior rectus?
Hypers. I've never seen a hypo, never in my life. As a matter of fact, the series from UCLA, the only hypertropias were mine. So I may be doing something wrong there, but I never.
I saw my first hypo. I don't know what I did, but I did a transposition and ended up with a hypo. I think it's one of the theories is that when we do that, we weaken the superior rectus action, and actually the hypotropia was worse in abduction and in elevation.
I think it's really important to mark where the superior rectus is going to go before you cut the superior rectus muscle off, because it's very easy to accidentally recess. Because I end up seeing patients who've had superior rectus transpositions elsewhere and end up with a hypotropia. And almost always I find that the superior rectus muscle was inadvertently recessed several millimeters at the same time. If I don't do that, then like Federico, the surprises are almost always hypertropias, but that's why I put those on an adjustable suture. So if I get it, if they wake up with a hyper of 5, I can let it out by a couple of millimeters in exchange for losing a little bit of abduction force.
I want to change topics for a minute. I wanted to ask Mary about genetic testing. First, which cases you like to do genetic testing on, and where do you send the labs? You have a lab there, but if I'm in Miami, where can I send? Is there a panel I can use that will be useful for cases if we suspect CCDD, or even do we ever order testing for regular strabismus, childhood strabismus?
Yes, so definitely anyone who looks like a CFEOM, I would send for genetic testing. There is a panel. Different companies have one, but Blueprint Genomics, I know, has one that includes all those CCDD genes. For isolated Duane's, we generally don't send genetic testing because the yield is low. I'd be more likely in a bilateral case or a syndromic case. But in a syndromic Duane's, either a panel depending on the other elements of the syndrome or just a whole exome at this point.
So let me ask you, I had a child recently with bilateral Duane's and the father has unilateral Duane's. Which test should I order? And the child, they were both isotropic, unilateral in the father, bilateral in the child.
I'd probably just do the sort of standard NeuroOp panel, which includes all the CCD genes, or refer them to Elizabeth Engel for the study if nothing comes up on the clinical panel.
Stacy, do you have any special recommendations for kids with neurophthalmic? I thought it was very interesting what you mentioned at the end with the facial expressions in these patients with Meavius syndrome. I think they're trying to improve that with all this reinnervation, facial reinnervation surgery and reanimation. Do you have any comments?
Yeah, I think it's just, like what I said, I think it's really important for families to understand that because I do think when children aren't able to interpret emotions and interact in that way, that sometimes they're misdiagnosed with other developmental disorders. I don't think that's totally widely understood by families, at least. So I think in that area, that particular piece of information sometimes gets lost on families and on people who are doing neuropsychological testing. In terms of other ordering and testing, I agree on the genetic testing and the neuroimaging because of all of the associations that we've mentioned.
Do you have any insight on the school performance of these children, like with Meavius syndrome, where they have horizontal gaze palsy? Does it affect reading? Parents always ask because in the school setting, it'll be important. The social interaction, as you brought up, because of the facial expressions and also the limitations related to the eye movements.
Yeah, I think any information we have is probably anecdotal because of the fact that these disorders are so rare. I'm not aware of any sort of like large studies looking at school performance. I know many of them are developmentally normal, and I usually tell families that it shouldn't impact reading very much. But we do know, of course, that strabismus and amblyopia can impact reading speed from Eileen Birch's group. So I don't have a great answer to that. That's based on data. It's more anecdotal, I think.
Yeah, I mean, there's a big group of Mobius kids that are developmentally delayed, and then a big group that are not. And as far as I know, they have relatively normal school performance, the ones that have normal intellectual.
We'll take a couple more questions from the Q&A, and then we can probably adjourn. So one is, does V or A pattern affect decision for superior rectus versus inferior rectus transposition? And I think you mentioned something in your talk, Federico. Maybe you want to take that one. A or V pattern to select superior rectus versus inferior rectus transposition.
Yeah, I definitely look at three things. I look at the pattern, the torsion, and the vertical deviation when I'm making the decision. Sometimes it's very difficult because, I mean, in theory, when you transpose a superior rectus temporally, you're going to create more torsion, but the evidence is that it's very rare that it's symptomatic. But if, for example, if you have a patient, and a lot of patients with Duane syndrome have much better abduction when they look up than when they look down. So just be very careful of doing a superior rectus transposition on that patient, because then you may end up having a huge exotropy in up gaze with not really much of improvement in down gaze. So I definitely look at that for sure. I don't know, David, Stacy, and Mary, what your thoughts are on that.
I think Amin Sinner published a series where he did inferior rectus transposition versus superior, and I'm sorry, I can't remember. I remember being confused about the result because it seemed like A patterns or V patterns could get worse or better with either transposition of the superior inferior rectus. So there wasn't any good obvious guideline to go with there, probably because of the disinnervations that are there in Duane syndrome that we don't see. I was hoping that that introduction and abduction, depression and attempted abduction might be a guide. but that doesn't help. And I've only done the inferior rectus transposition a few times, and like I said, it just didn't seem to get the same effect. So I haven't done it enough to say further.
Yeah, I think that's been reported. It's been reported that there was less effect on the inferior rectus than the superior rectus. I don't have much experience with inferior either, but I have recently a case with a large exotropia and upgaze, and I look back and I kind of missed that isotropia. She had a V pattern to start with, so probably if there's a significant V pattern, inferior rectus may be more appropriate, at least try to avoid that exotropia and upgaze. They were asking about torsion. I think we've addressed that. Do you have any comments on the torsion with unilateral transposition of a vertical muscle?
Well, I mean,
Okay.
we saw intorsion for sure. Every time you transpose it, you get intorsion. Now, symptomatic intorsion is very rare. We only have, I think in our series was less than 15%, I don't remember. It was a small series of patients, but we actually look at it systematically on a prospective basis. And yeah, but I just tell you, whenever you get it, it's really a problem because it's really hard. Patients have to really do a lot of tilting, plus that they don't have normal motility. So now it's really hard to compensate for the torsion.
Yeah, and those are the patients where if you've already done superior, you just taking out at least the augmentation suture. But if you see, significant intorsion, anatomic intorsion of the eye before doing surgery, that's the one that I probably would do inferior rectus transposition. So as to avoid, if it's already, if they're ever got +2 intorsion for whatever reason, you don't necessarily, and they're few binocular, you don't want to make that worse.
We'll take one final question here from the QA. It says, does doing a Scott procedure on superior oblique improves elevation in hypotropia with type 1 CDD?
I was going to answer that, but I don't know what the Scott procedure on the superior oblique is.
That's when you bring it between the superior rectus. You cut a tendon nasal to the superior.
Oh, nasal transposition.
Bring it between the superior rectus and medial rectus muscle. So
well,
you can down closer to the medial rectus to try to.
It's already there half the time. so you got to find it temporally. It's not there. It's already attached nasally. So that's why I just cut it off.
It's not going to do much for you. And there was a comment earlier on whether you have tried Nishida when you do the inferior rectus recession. Have you tried doing a Nishida superiorly, moving the horizontal muscles towards the superior rectus muscle to improve subreduction in patients with CCDD type 1?
So I've done it in patients with neural, with other reasons, but the problem with the CCDD patients is that you just don't know what's happening with the horizontal rectus muscles either. So if you try to start transposing bellies of tight muscles, it's just, maybe you'll get lucky, but it's a dangerous path to take, I think.
Opening a surprise box.
I think you can add one more there. I think similar to the concept of superior rectus transposition plus medial rectus muscle, doing a inferior rectus recession with one horizontal muscle moving up is a very powerful procedure. We actually had a small publication with the Stacy and another member, fellow of us, and I actually have overcorrected patients by doing that. So I tell you, is probably something that you can maybe consider.
In CFEOM?
No, knowing if the patient had a normal horizontal rectus muscles, because you have to get rid of the inferior rectus. So now you're getting rid of everything there in the orbit, and you're touching all muscles. Yeah.
Okay, well, I think we've had a great discussion, amazing presentations. We really enjoyed all of them. And again, I learned a lot from all of you. So I think we should conclude that meeting because it's already 1 p.m. and it's Saturday. And well, 1 p.m. here is better for you. It's earlier there. But time to go and enjoy your Saturday. So thank you very much. Thank you, Burt, for being honored and allowing us to enjoy this webinar every year. Thank you, Federico, and congratulations on your medal, and you worried to stay away from COVID. And thank you all the other speakers for your amazing presentations.
Thank you all.
The rest of your day.
Very much. Thank you.
Bye.
Thank you.